Time to get into some biomechanics.
Love it.
Today we're going to do a deep dive into the knee and the hip.
Yeah.
And this is really key stuff for any orthopedic resident out there who's got those big postgraduate exit exams coming up.
Absolutely.
So we're talking FRCS or any of those equivalent fellowship exams.
Yeah.
So to make sure we're all up to speed on this, we're going to be using some notes called Ortho Made Simple.
Oh, yeah. I've seen these.
And they're from a website, mokyingren.sg.
Okay.
And these notes were actually put together by a guy called Dr. Mok Ying Ren. He's a sports surgeon from National University Hospital in Singapore.
Okay.
And he aced his FRCS exams back in 2022. So
all right.
we know we're in good hands here.
So yeah, these notes are really a goldmine for really getting into how these joints actually work.
Right.
Which is, exactly the kind of stuff that they love to grill you on in these exams.
Yeah, for sure. And I always thought one of the most fascinating things when it comes to the knee was this concept of femoral rollback.
Uh-huh.
Now it's not just a simple backward movement, is it?
Well, you're right. It's definitely a bit more complex than that.
Okay.
So, yeah, as your knee flexes, those contact points between the femur and the tibia,
Right.
they do move backwards posteriorly.
Yeah.
But the actual rollback itself is more like, well, think about it as a combo of rolling and sliding.
Oh, okay.
And the lateral femoral condyle is really the key player here because, well, if you think about it, the lateral tibial plateau, that's the one that's more convex.
Right.
So that means the lateral femoral condyle's got more space to really roll back.
I see. So it's not just a simple, straight back movement.
Yeah.
It's also dictated by the shape of those joint surfaces.
Exactly.
So why is this so important for us to understand?
Well, think about it this way. Let's say you're doing a total knee replacement.
Okay.
You've got to make sure that implant's going to allow for that natural rollback motion.
Right.
If you don't, well, you could end up with impingement. You get limited range of motion, and you're even risking speeding up the wear and tear on that implant.
Oh, wow. So it's not just a theoretical concept, this femoral rollback. It actually has a real impact on how we approach those surgeries.
Definitely.
Okay, well, let's move on to another one of those classic knee concepts.
Yeah.
The screw-home mechanism.
Yeah.
So what is actually happening when we say the knee is screwing home?
All right, so picture this. You're standing up straight, knee fully extended.
Okay.
Now, in that position, your femur is actually internally rotated just a bit on top of the tibia.
Okay.
So that's your screwed home position. And it's actually super stable and doesn't need much muscle effort at all.
Wow, so efficient.
Right.
Yeah.
But then when you want to unlock the knee and start bending it, the popliteus muscle comes into play. And that's what externally rotates the femur to get that flexion going.
Interesting. So the popliteus is like the key to get the knee moving.
Exactly.
But what causes that internal rotation in the first place? Is it just the muscles?
Well, it's not just the muscles. It's a whole team effort.
Okay.
It's the shape of those joint surfaces, the ligaments and the muscles all working together.
Right.
And remember how we were talking about the lateral tibial plateau being more convex?
Uh-huh.
Well, that asymmetry, along with the fact that the center of rotation's on the medial side,
Okay.
well, that all kind of guides the femur into that internal rotation as the knee extends.
Wow, it's like a perfectly choreographed dance between the bones, ligaments, and muscles.
It really is.
Now, how does all this relate to those kinematic models we always see in textbooks? I sometimes find them a bit hard to picture.
I hear you. Well, those models are really just trying to simplify all the complex movements that are happening at the knee.
Right.
One that you'll probably see a lot is the 4-bar linkage model,
Okay.
which is basically focusing on those cruciate ligaments, the tibia and the femur.
Mm-hmm.
And it helps us understand how flexion is actually both a rollback and a sliding motion at the same time. Then there's the degree of freedom model, which tells us that the knee actually has 6 degrees of motion, 3 rotations, and 3 translations.
Wow, 6 degrees of motion. That's a lot to keep track of.
Yeah, but it makes sense when you think about all the different ways the knee can move.
Absolutely. Okay, let's zoom in on one particular structure. The IT band, or ITB.
Right.
What's its role in keeping the knee stable?
Well, think of the ITB as this strong supportive band running along the outside of your thigh.
Right.
And it's all about where it sits in relation to the knee's center of rotation.
Okay.
So when your knee is fully extended, the ITB is in front of that center and it acts like a passive restraint, helping to lock the knee in place.
Okay.
Which basically means you can stand up straight without your muscles having to work too hard.
So it's like a built-in stabilizer. Amazing how the body just does that.
Yeah, it's pretty cool.
All right, now shifting gears a little to talk about the patellofemoral joint.
Okay.
You know, I love a good force diagram.
Of course you do.
So walk me through how the forces are working on the patellofemoral joint, particularly when the knee is bending.
All right, so let's try and draw a simple free body diagram of that joint.
Okay.
So you've got the quadriceps tendon pulling upwards,
Right.
and then the patellar tendon pulling downwards.
Mm-hmm.
And let's say, to make it easy, those forces are equal.
Okay.
Now, the important part here is that the resultant force from those two, and therefore the joint reaction force, they actually increase as the knee flexes.
Wait, so the more you bend your knee, the greater the force on the patellofemoral joint.
Exactly.
That seems a little counterintuitive. Why is that?
It's all about the angle between those two force vectors.
Okay.
So as your knee bends, the angle between the quadriceps and patellar tendon forces gets smaller.
Right.
And that actually increases the size of the resultant force.
That's like if you're trying to push open a door.
Yeah.
It's much easier to do it straight on than at an angle.
Exactly. Perfect analogy.
So before we get into the hip, I just want to remind everyone listening that all this amazing info is coming from the Ortho Made Simple notes,
Yes, definitely check those out.
which you can find on mokyingren.sg.
It's a great resource.
Yeah, especially if you're an orthopedic resident getting ready for those exams.
Couldn't agree more. And don't forget, all these biomechanics we're talking about today, they aren't just going to help you ace those exams. This is the bedrock of your clinical practice.
Absolutely, for sure.
All right, so let's switch gears now and talk about the hip.
Okay.
Another joint with, well, some pretty amazing biomechanics going on.
Yeah, for sure. And I'm really starting to appreciate the importance of understanding those forces, like you were talking about with the knee.
Oh, absolutely. Forces are key no matter which joint we're talking about.
So how do they play out at the hip, especially when we're thinking about, like, a patient in single leg stance?
Okay, great question. So picture your patient standing on one leg.
Okay, got it.
Now think about all those forces acting on that hip joint. You've got the weight of their body pushing downwards, right?
That's a big one.
That's our first force vector.
Right.
But then, to counterbalance that, you've got those abductor muscles firing away.
Okay, yeah.
Especially that gluteus medius, working hard to exert an upward and outward force.
So I can picture those vectors now, the downward force of the body weight, and then the upward and outward pull of the gluteus medius.
Exactly.
But it gets even more interesting when we start adding in some other elements, right?
Oh, for sure.
Like what happens if our patient is using a cane?
Excellent point. So let's say they're using a cane, but on the opposite side.
Okay.
That cane is going to introduce a whole new upward force. And that actually helps to reduce the load on that hip joint.
So it's like having an extra support system to share the burden.
Exactly. It's like an extension of their arm, helping out those muscles.
That makes a lot of sense. Now, what about if they're carrying something heavy on that same side?
Like a heavy bag.
Yeah, a heavy bag.
Oh, well, that's going to do the opposite. That's going to add an extra downward force, working in the same direction as their body weight.
So it's increasing the load on the joint.
Exactly. And that's why understanding these forces is so crucial, because it helps us guide our patients.
Right.
You know, whether we should be recommending a cane or advising them to avoid carrying heavy loads on one side.
Absolutely. It's like those force diagrams suddenly become really practical tools.
I really do. All right, so now let's talk about how we can actually change those forces with surgery.
Okay, good idea.
And one good example of that is medialization surgery.
Yeah. What's the impact of that on the forces around the hip?
Well, basically what you're doing is shifting the hip socket closer to the midline of the body.
Oh, okay.
And that's important because it changes the way those abductor muscles, you know, the gluteus medius we were talking about, it changes their leverage, makes them more efficient at counteracting that downward force of the body weight.
So it's like repositioning the fulcrum to give them a better mechanical advantage.
That's a great way to put it, yeah. And the result is, you guessed it, a reduction in that overall joint reaction force.
Oh, that's clever. Now let's get into some clinical presentations.
Sure.
First up, the Trendelenburg lurch.
Okay, classic one.
What's happening biomechanically to create that kind of distinctive gait?
Well, think about what happens when those abductor muscles, particularly the gluteus medius, aren't strong enough.
Right.
This could be due to a bunch of things, hip arthritis, nerve damage, you name it.
Yeah.
But basically, when that weaker leg has to bear weight, the muscles can't stabilize the pelvis properly.
Okay.
So it drops down on the opposite side.
So that's what's causing that waddling or that lurching gait.
Exactly. It's all about that pelvic instability.
Now, what about if we're looking at a patient with AVN, a vascular necrosis of the femoral head?
Ooh, yeah, AVN.
How does that change the biomechanics of the hip?
Well, AVN is a pretty serious condition because, well, the blood supply to the femoral head gets cut off,
Right.
which means the bone starts to die and eventually it collapses.
Okay.
And that's a big problem because it reduces the offset between the femoral head and the shaft.
And why is that a problem?
Well, think about it. It basically shortens the lever arm for those abductor muscles.
Oh, right. So they have to work harder.
Much harder just to stabilize the pelvis.
And that means...
Significantly increased joint reaction force.
Ouch. That sounds really painful. Okay. Last clinical scenario for you.
Hit me.
Imagine a patient with L45 radiculopathy.
Okay.
Now, that can cause weakness in the muscles that extend the hip.
Right.
So which side should they be holding their cane on?
Ah, that's a classic exam question.
It is, isn't it?
And the answer is the opposite side.
Okay.
So, contralateral to the affected leg.
And why is that?
Because by holding the cane on that side, they're creating an upward force that helps to compensate for the gluteal weakness,
I see.
which ultimately reduces the strain on that affected hip.
So it's all about strategic placement of that cane. Fascinating. Now, we've talked about a lot of problems here.
We have.
So let's switch gears and talk about solutions. How can we reduce those joint reaction forces?
It can be really effective.
Okay.
Lateralizing the abductor muscles, that can give them a better mechanical advantage. And of course, something we can't forget, weight loss.
Always a good idea.
Huge impact on reducing the load on the joint.
Yeah, absolutely.
And then we can also think about those external aids, like using a cane on the opposite side,
Right.
or even carrying a bag on the same side as the affected hip.
So it's all about lightening the load and optimizing those mechanics.
You got it. Now, before we go too far, let's just back up and make sure we're all on the same page about basic hip movement.
Okay, sounds good.
How many degrees of freedom does the hip joint have?
3.
3. You got it.
Okay.
It's a ball and socket joint, so you've got flexion and extension,
Right.
abduction and adduction, and rotation.
Okay, so that's what gives us that incredible range of motion at the hip.
Exactly. But it also means there's a lot that can go wrong, as we've been discussing.
Very true. Now, thinking about everyday activities, how does something as simple as walking affect the hip joint reaction force?
Well, even normal walking generates a force of about 3 times our body weight.
Wow.
But if you pick up the pace and start walking fast, that force jumps up to a whopping 7 times your body weight.
Really? 7 times?
7 times. And even something like a straight leg raise generates about twice your body weight.
Wow. Those are some serious numbers. It really emphasizes why understanding these biomechanics is so important for us orthopedic residents.
Absolutely. And remember, all this information comes from those excellent OrthoMade Simple Notes.
Yes, a great resource.
You can find them on mokyingren.sg. Dr. Mork has done a fantastic job of taking a complex topic and making it easy to understand, which is exactly what you need when you're prepping for those exams.
Yeah, those notes are a game changer for sure. Okay, so before we wrap up this deep dive into the knee and the hip, let's take a moment to recap the key takeaways and get ready for the final stretch. All right, we're back, ready to wrap up this deep dive into biomechanics.
Yeah, we've covered a lot of ground.
Femoral rollback, screw-home mechanism, all those force diagrams, clinical presentations.
It's been quite a journey, all thanks to those OrthoMade Simple Notes by Dr. Mok, of course.
Definitely.
You can find them over at mokyingren.sg.
Seriously, a must-have for those exams.
Absolutely.
But how does all of this actually help us in the real world, in clinical practice?
That's the key question, isn't it?
So let's say you're an orthopedic resident, you've got a patient coming in with knee pain. Where do you even start?
Well, you start by thinking about all those biomechanics principles we've been talking about.
Okay, so we're not just throwing all that knowledge out the window.
Definitely not.
So what? We start with a really thorough history.
Exactly. Where's the pain? What kind of pain is it? When did it start?
Okay, yeah, the basics.
But then you dig deeper. Is it worse with certain activities like climbing stairs, squatting, that kind of thing?
Because those movements put different stresses on the joint.
Right, exactly. And that's where understanding things like femoral rollback, the screw-home mechanism, all of that comes into play.
So you're saying it can help us narrow down the potential causes.
Exactly. Let's say the pain's worse with deep knee bending.
Okay.
Could be a problem with the patellofemoral joint.
Oh, right, because we were talking about how those forces increase with flexion.
Exactly. So those force diagrams, they're not just theoretical. They actually help you think about what might be going on.
Wow, so they actually have diagnostic value.
Absolutely. And then your physical exam, well, that becomes much more targeted.
So you're looking at range of motion.
Yep. Checking for any signs of instability, tenderness in specific spots.
All guided by your knowledge of the anatomy and the biomechanics.
Exactly. And don't forget to check those muscles, too.
Oh, right. Strength and flexibility.
Because if those are out of whack, that can really throw off the mechanics.
It's like putting together a puzzle, isn't it? Using all those biomechanics clues to help you figure out what's going on.
It really is. And once you've got a good idea of the problem, then you can start thinking about treatment.
So we might be talking physical therapy, bracing.
Exactly. Or maybe surgery, depending on the situation.
So it's a whole process, all starting with that solid understanding of biomechanics.
It all comes back to the basics.
Well, to all those residents out there getting ready for those exams, just remember, this isn't just about memorizing facts.
It's about understanding how the body actually works.
And then using that knowledge to help your patients.
Exactly.
And a big shout out again to Dr. Mok and those Ortho Made Simple notes.
Definitely check them out.
On mokyingren.sg, they'll definitely give you a leg up.
For sure.
All right, well, that brings us to the end of our deep dive into the knee and the hip.
It's been a good one.
It has. Keep those brains working, everyone. Keep learning. And most importantly, keep that passion for orthopedics burning bright.
Couldn't have said it better myself.
Thanks for joining us on the Deep Dive.